Hey, good morning. Thanks for hanging with us. Um, sometimes things get a little. We're supposed to be running a nice, well organized, well oiled machine around here. And this morning I'm running around like a chicken with its head cut off.
Well, we do have a guest in the
But
studio,
we do.
as
We have
always,
a
Dr. Tripp.
regular guest in our studio, and this would be Dr. Tripp from Tripp Family Medicine.
I am. Or at
So,
least I'm still the same guy.
yes, he
That's
looks
right.
the same, even though I don't see him but infrequently. But it's nice to have you here.
Okay, so what's on the agenda today,
What
Dr.
do you want
Tripp?
to talk about, Doctor?
We have a big topic. I have some housekeeping items we'll go over as well, but today mainly what we're going to talk about is infection, why we get it, how we treat it, and how we get it as part of it. So it's how we
Okay.
get it, how we treat it, and then some things about
And don't ignore it, of course, right?
yeah differences between what are called local versus systemic infections.
Okay.
And we got a couple of things I want to bring up first.
Now, there's a lot of people around here who will tell you that I am the primary source of infection and we need to eliminate me.
Well, I don't know your wife, but I haven't received any information to say we should go after you personally. Although, if your name is Influenza A or B, we can talk about that.
Uh-oh.
Oh.
In fact,
If
kind
there's
of
an A and B, okay, so what does that
Yeah,
mean, A and B?
tell
Because,
us the difference
all
there.
right. It's like the A team and the B team. You
okay,
know, you have different strains of influenza, and the truth is the A and B each represent huge groups of different viruses. You know, a lot of people say, why don't we get a vaccine for the cold virus, thinking that maybe it's a single virus or two, but cold viruses are hundreds and thousands of different viruses. So once you get one and you get over it, you're immune to that virus, but not to the other 1,000 or 10,000.
okay.
And so that's why we don't have a single vaccine for the common cold. The flu, on the other hand, does have many different viruses, but they tend to go in groups or in families. And so each year, the flu vaccinators or manufacturers of flu vaccines are trying to put together the top 3 or 4 flu viruses that caused trouble last year. And then they group that into a single vaccine, which we call our flu shots, and in hopes that this year's flus will be either the same or a mildly changed version of last year's because they mutate. They don't remain the same. And if that's true, you'll get at least partial immunity. So if you get sick, it won't be terrible. But the flu typically knocks you right down for about a week in bed and has the great threat of pneumonia and death. And in fact, as advanced as we are over the last century with uh, medications and technology, pneumonia still kills 20% of the people that it infects. So
And
whether it's viral or bacterial, whatever the cause, 20% of people, 1 in 5, die if they get pneumonia. So it's a big deal.
well, and last year was pretty severe as well for
Last year is the worst year for deaths due to influenza that we have since we started keeping track. There are worse epidemics that we know, like there was what's called the Spanish flu of 1918, and it killed more people than we lost in one of the civil, and not the Civil War, but the World War I or World War II. So it was much bigger than last year. But we had 80,000 people die last year,
well,
In
and
the United States,
in the United States,
80,000.
and most of those are going to be seniors and infants,
okay.
and so they're not the typical 20 to 50-year-old because we'll usually fight it off.
Hmm.
But the truth is when it's the worst year last year, the types of flus that are going to show up this year are likely to be what gave us such trouble last year. So this year, Centers for Disease Control and other medical groups are really pushing everybody. If you don't normally get a flu vaccine, this is the year to do it. Because if we get the same stuff as we had last year or a mutation of last year, it can be even worse than last year.
Okay.
So that's my push on flu vaccines. There's
Okay.
different types, and I will warn you that I won't say there's a shortage. There's a shortage at my office for the 19 to 64-year-old group, but anybody over 65 and anybody up to age 19, we have the vaccine today. We expect the others to arrive any day, and the goal is to get everybody vaccinated before October is over. And, we're talking 2, 3 weeks.
Okay, all right.
So
So get prepared
Wow.
for that. Okay, so like you said, there's different ways that you can get an infection. It's not just one way.
Yeah, let's
It's
stick
tricky
with,
that
let's
way.
stick with the flu. How do you get the flu?
Okay, so how's that work?
Because most people, when I grew up, I was understanding that the flu was nausea, vomiting, diarrhea, and that is not the flu.
Okay.
That's another virus that causes you a stomach trouble.
They call it the stomach flu, don't
Yeah,
they?
yeah. Frequently it's
I mean,
referred
that's
to
a
as a
common.
stomach flu.
Okay.
But it's confused because people don't know what the symptoms are. So think of your common cold, congestion, headache, fever, but add body aches to that. And the body aches are the biggest factor that say, hey, this is the real flu. This is not just your
and
common cold.
This is full body. I mean, from head to toe, your body just aching.
Frequently, it's the whole body. When we had the swine flu several years back, it was mainly in the thighs. It was really interesting that if
Okay.
I had somebody call up and say, my thighs are killing me and I'm sick, I almost knew without even seeing them.
Okay, we'll be back with Dr. Tripp right after the break.
Okay, we're trying to determine what we need to do to stay healthy, and we're all going to go
And
get flu shots
And avoid infection.
and
avoid
avoid
infection.
infections. Absolutely.
Okay.
So the only question I have on flu shots is, you want to get that all done before the end of October?
That is the hope
The
of
hope. What
and
if I wait until sometime in November to do it?
do it anyway. In fact, even clear up till next April. But the chances of getting sick are highest between about October and December. So the flu continues until the warm weather hits. And it's still around, but it's just not as prevalent.
So the efficacy period on the flu vaccine is about a 3 or 4 month window.
Well, the vaccine itself will last for a whole year, but the major time to get the flu is going to be October through about December, January. And so if you want to avoid 5 days or 7 days out of work and in bed, then probably you ought to get it sooner than later. You know, if you're traveling, you're very likely to catch colds, on a plane, on a bus, whatever you're doing, because you're in close proximity, recirculated air. And so, I personally am going to be traveling this weekend, and I am looking for a flu vaccine that my office doesn't have today.
Uh-oh. Well,
So,
but you'll have it by
yeah, probably
weekend
by the time I get back, after I go on the
Yeah.
plane.
Very good. Okay, you had
So-
So it's always good to wash your hands, like you said. That's
Yeah,
one way to get
let me talk about how to catch or not catch the flu.
Okay.
Washing your hands, but especially just before you eat anything, because a lot of what we catch, we put in our own mouth, or I hate to say it, when we pick our own nose.
Mm.
So, wash your hands before you pick your nose instead of just after.
Right.
Isn't that a terrible thing for a doctor to say?
Yeah.
But reality.
It's something we do, like you said.
Yeah,
reality.
I mean, I saw a comic one time that showed some church lady sitting next to, God apparently just passed the pearly gates, and they were the only ones there, and the response was, well, you're the only one who never picked your nose. So we all do it,
Yeah. we
So
do.
Oh.
Okay.
so the way you catch the flu mostly has to do with what are called respiratory droplets. Somebody coughs, sneezes, it's in the air. And by the way, coughing isn't always due to illness. It's a lot of a natural protective mechanism of our airway. But if you have the flu, you are shedding it like crazy every time you cough. And so some of the rules we need to learn to do, if we don't have a handkerchief, is to cough into your elbow, especially if you got long sleeve shirts. It will filter a lot of that. Coughing in your hand essentially allows you to put your hand on the next handle or doorknob or whatever, and whoever grabs that doorknob and then touches their own face administers, a whole new dose of flu to themselves. So coughing into your elbow or your shirt sleeve is a great move to help protect others. But, if you think of people that have infants around under 6 months of age, they can't get an immunization. So you have to form kind of a protective circle, circle the wagons around that infant that can't be immunized by getting immunized, and then taking precautions not to spread in case you do get sick anyway.
Okay.
So respiratory droplets, stuff that's in the air, you and I inhale it. Sounds terribly gross, but that's the way viruses survive, is they get passed from one host to another by essentially inhaling it or touching it and putting it in your own mouth. So washing hands, if you have a decreased immune system, wearing a mask,
Okay. So just those standard little white masks you
Yeah,
get at the hardware store?
something that's, you can get them at the hardware store. They need to be able to pinch around your nose and fit relatively tightly.
Okay.
They don't have, if you're on chemotherapy and had really low immune system, or somebody that had HIV and was at end stage AIDS, they would need to have what a lot of our construction guys know, and that is called an N95 mask. It's a high density particulate mask. And that one's a little harder to breathe through, but boy, does it filter well. But just your general mask, if it fits to your face, will help you avoid a lot of stuff. And I see people, again, like traveling on airplanes or otherwise, they'll wear that if they have a decreased immune system. And the truth is in some of our Asian countries, it's very common for people that aren't ill or immune suppressed to wear those out in public because they know other people are out there with illness. And,
and they don't want to get sick either.
yeah, it's not our culture, but if you have any worries, maybe you make it your culture.
Okay. All right. But even too, just not touching your face is a good step, right?
It is. It's a great step. If you start putting your hands towards your face, think twice, wash your hands, then you go ahead and touch your face.
Okay. Sounds good. Or stay home, right, if you can.
Well, yeah, I'm not a proponent of being a hermit, and hiding out. We're a social people, but if you take common precautions, you can avoid a lot of trouble, a lot of illness. And what I would call common is the hand washing, being careful of who you're around with coughing, and getting immunized.
Okay. And that's
and
the
by
trick.
the way, the egg allergy to the flu virus is no longer a contraindication. If you had stopped breathing and that was your reaction, I would say, okay, we'll not do that. But if you got a little bit of a rash or a sore arm and you say, hey, it's because I'm allergic to eggs, there is so little egg component to these vaccinations, and it's not in all of them, that you will unlikely have any kind of trouble. And if you do, make sure you get that immunization at your doctor's office because, we've got stuff right there to slow it down, a little bit of Benadryl, and if we need to, some epinephrine. And but the reality is a little rash for a day versus being truly knocked out in the threat of death. I'd
For a
take
whole
the
week.
rash. Yeah.
Yeah, that was an easy decision.
Okay. So it's so
Yeah.
minuscule that it's not going to be a
So
major
I didn't mean to
reaction, right?
spend this much time on the flu, but 'tis the season.
It is, right.
Here's the seat.
Yeah.
Now you had one other item that you wanted to talk about, and that's some changes that the.
This could take the whole rest of the show. But,
Okay. Well,
All
I'm
right,
good. The
let's-
whole rest
let's
of the
talk
show.
about it.
Because we'll have to come back and talk about all the other types of illness, going from local to systemic if we can't get through this. But this is important. And I was telling our hosts that I usually don't bring anything political to my discussion about better health, but this is about your health. And the Centers for Medicare, it's called CMS, proposed in late August or September changes for 2019. So we're talking next year. We're not talking about a decade from now. And the proposal is simply this. Right now, there's about 5 different levels of office visit codes or charges, depending on how complicated your visit is. If you come in because you got pink eye or ingrown toenail, that's a cheaper visit than if you come in to talk about your blood pressure and your diabetes and your congestive heart failure. Or you're coming in with chest pain. That's a very different level of medical decision making and comes with a higher charge. So people often say, well, how much is it going to cost today? And the answer is often, well, it depends, because that's set up that way. So Medicare has decided, and this is Medicare specific at first, but other insurances often follow their course.
Okay.
Medicare has proposed that we make one-size-fits-all charges. I guarantee that charge is going to be on the lower end, maybe not the lowest, but second lowest out of those 5 charges. And they have proposed this and said this is going to leave so much more time for the doctor because he won't have to figure out what level of office visit this in. That decision making about the office visit level is a moment that will not save the doc any time. It's all the other data entry that is now required thanks to the changes that have happened in the last about 5 years that Medicare requires and now other insurances require. And they call it value-based payment instead of fee-for-service. But essentially they're saying, hey, this is going to save the doctor so much time. He'll have more time for the patients in the office. It'll all be a win-win. But the reality is they're going to decrease the doctor's pay, and the patients are not going to be allowed to talk about more than one thing at a time because one size fits all. So if you have come in and you say, hey, I'm just here for my blood pressure, but you want to talk about that mole on your back, you're going to be told, we can't even look at that today because we can only charge you for one thing.
You scheduled for one event, or one examination, and that's all we're going to do. If you want something else, we will schedule you for another visit at another time, and we'll talk about it then.
And guess what? If you have 5 things we need to talk about,
That's 5 visits.
your diabetes, your hypertension, your mole on your back, and the anxiety that we've been struggling with, that's going to be 4 or 5 visits right there. How many of you want to come back, once a month, once a week to get through what typically we do in one visit? That's what this proposal is about. And the truth is patients won't come back. Their health care will go down. Doctors will be paid less. And already, just so those of you on Medicare know, Medicare is, if not the lowest, second lowest payer out of all the payers that are out there. I generally, for the same visit for a Medicare patient, get about $30 to $40 less per visit than when I see a Blue Cross patient. So just sheer economics, docs getting paid less and having to see you many more times to try to get the same treatment done is going to cause a lot of docs to say, I'm just done with Medicare. And that is going to put the Medicare recipients in a heap of trouble, to use vernacular.
Mm-hmm.
So my suggestion on this is look into it. See if the 2019 proposals by CMS don't say what I say they say. And if you believe that, you need to be calling your senator and your congressman, because right now they're planning on moving forward with this. They had a 30-day comment period that nobody knew about that ended September 10th. I found out about September 2nd. So many doctors don't even know this is coming about.
So they really haven't. So it sounds like they really haven't consulted practitioners about this.
Oh no, this is not meant.
This is top down. Right?
Yeah, this is not doctor consulted. You have the Academy of Family Practice, the AMA, all screaming about this now that it looks like they're trying to move forward with it. But it came about quickly, and the decision making does not really involve the public, and the public doesn't even know it exists or that the threat is there.
Well, and I think
that is another one of the casualties of this Kavanaugh debacle that we just had the last 4 or 5 weeks in Washington, D.C. And according to Dr. Tripp, it's going to affect everybody in my category.
Yeah. No, I'm seeing a patient yesterday that's telling me about how I see his parents. And I said, if they had the same things you, the 50-year-old, had, I'd have to see you 4 different visits to do the same thing we did today. And I said, that's going to have a huge impact, not only on the payment to the doctor, which you've heard me already complain about, but how many of you as patients tell your doc, I don't want to have to come back next month? And that's because they've changed your blood pressure medicine and they need to follow up with you in a month.
Uh-huh.
But this will be strictly a payment/rule coming from Medicare down, saying one size fits all. And the truth is one size does not fit all. So if you're really healthy, you won't care, because you won't see the doc anyway. But if you have minor issues like thyroid disease, you're going to have to see the doc a whole lot more often for it to be worth the doctor seeing you.
So this takes more time and
takes more of your time.
Right.
Well,
and
2 things. I can see where it's going to take a lot more scheduling time with the doctors and their office, their staff, and it's going to take more of my time because I'm going to have to keep going back there multiple visits because we can only have a one topic conversation.
And when CMS put out this proposal, their whole slant on it was, we are going to make more time for the doctors by making this change, and they're going to spend more time with you, and nothing could be farther from the truth on this rule.
Sounds like the government getting in the middle of things again, doesn't it?
So it sounds like they decategorize the whole payment system as like you guys said, it's tiered, and I think a lot of people don't even understand how they're billed.
Correct.
They leave it to the insurance. The insurance takes care of it. I'll be guilty of that because you don't know what to
as
look
long
for.
as it doesn't come out of your pocket, you kind of say, I don't know.
Exactly.
I don't
You
care.
got your $30 copay. You
right.
go in, you pay
and
that.
I'm not saying that's a great system,
right,
but to go to one size fits all, and especially to make that payment less, is not going to work for Medicare patients.
So what happens? So they go in for, say, hey, I stubbed my toe, just as a very loose example.
Sure.
And then all of a sudden you say, ooh, you got high blood pressure. Oh, wait a minute. I think you might have diabetes.
We're going to have you come back and talk about
because
that.
you can't talk about it.
Why don't we set 2 or 3 more appointments to make sure we get those things covered? That's exactly what the doc will have to do.
You want to take a phone call? We do have a phone call.
Sure.
All right. Good morning. You're on with Dr. Tripp this morning. Go ahead.
Yeah, good morning. I was just wondering what the doctor's opinion was on Proposition 2 and which way he would go on that.
Proposition 2 is about expanding Medicare in Idaho. Medicaid. Yeah, we've been talking Medicare. Let me distinguish. Medicare is for the 65-year and older crowd. Medicaid was initially meant mainly to help with children in poor populations, but now includes pretty much anybody in a poor population and anybody with a disability that has qualified for disability. Medicaid is there as a safety net to try to help support them, keep them going. And my own mom, in my first practice, I took Medicaid. I don't now, but my own mother for about 3 months was on Medicaid. She had end-stage renal failure and diabetes, and really was a real lifesaver for her financially to have Medicaid for a brief period of time. But the intent is this was not supposed to be a permanent fix, and what we are doing with expanding this is essentially saying, okay, now we're going to expand it to a little higher income level, which sounds great on the surface, but it essentially, like it does right now, if you work and make, I'll make it up because I don't know the exact numbers, but if you make $8 an hour, you can qualify for Medicaid. If you make $12 an hour, you no longer qualify. Now you get opted out. And so you truly become part of what we call the working poor. You're working hard and now you're making $12 an hour, but having that specific limit says we will not, in fact, we have a lady that works for us right now. She was deciding whether she could continue to work for us or quit because she wanted to keep the Medicaid benefits. And so she was ready to quit and take less money because she wanted the benefits. And
she didn't want to slip over into that no man's land?
Exactly. And so the idea behind Proposition 2 is to create more people that don't have a no man's land, but it actually creates a new no man's land, and it supports the hospitals more than it supports the people.
Real quick, how do we get a hold of you, Dr. Tripp?
Oh, yeah, here we go. Website, trippvalleymedicine.com. Facebook is Tripp Valley Medicine. Telephone number, 208-933-4400. That's 208-933-4400. Love to see you. This is probably the most political discussion I've had on the radio yet. But this
Which
one,
you don't like to get into too much.
I don't. I hardly ever do. But this is about your health, and so consider Proposition 2 very carefully. It has good and bad ramifications, but I think I don't have a great answer saying it's absolutely should be one way or another. It sounds like I'm being a politician, but I really am on the fence about it because I see benefits and I see real drawbacks.
Okay, well, Dr. Tripp, thanks for coming in this morning and joining us as always every week with Better Health with Dr. Tripp, Family Medicine. We'll talk to you later.
We'll finish our infection topic next time.
Okay, sounds
Yes.
good.
All righty.
Thanks, Doctor.
Thanks.